and share my screen. Let me see. Okay, here we go. So welcome everybody again to today's rounds. So the goals today is really to introduce you to the surgeons and the team, because the team has actually changed over time, and some of you may or may not be aware. So obviously people who work here know, but there's lots of changes happening. The numbers, so how many procedures were done and how we're sort of servicing the province, and the challenges that we have with resources, obviously, and I'm sure all of you have, the impact on our patients. What does that mean in terms of morbidity and obviously wait times, and really a positive future that I hope to convince you of. So our team, and I think Rand is on this call. So Rand was here until a few years ago, still comes and assists with us on Tuesdays. So it's a pleasure to have him in the operating room on Tuesdays. I was with him yesterday. Sorry, I don't have a picture of Chris with the group, so we do need a group picture. Here's Chris. And unfortunately, in the summer of last year, Ansar left us, the New Brunswick Heart Center, for a new job in the United States, in Portland, Maine. So we've been functioning with 4 surgeons since the summer of last year, and been trying to obviously maintain services the same way as whether we were 5 or 4. And hopefully I can convince you that we've done our best to achieve that, as far as I can tell. So just a bit of perspective on the Heart Center. If you remember, the Heart Center has been here since 1991. In 1991, there were 4 cardiologists, 3 interventional cardiologists, and 2 cardiac surgeons. And in 2022, as of present, there are 6 cardiologists, 7 interventional cardiologists, 4 or 5 surgeons, depending on recruitment, obviously, and 3 electrophysiologists now, and 4 cardiac anesthesiologists. So obviously the Heart Center has grown, but some things have not changed and has really impacted us in the way we function. And I'll try to explain that as best I can. So unfortunately, as you might imagine, the demands for cardiac services, particularly high in New Brunswick, we're facing quite important population pressures. I was trying to find the exact replica of this figure here with the new census data that came out of last year, the 2021 census. But what's most important, if you imagine this bolus of baby boomers that were in the 1970s, young age, the 2008 or 18, sorry, were reaching the age of retirement, while that bolus of people is now in the age of high resource requirements from a healthcare point of view, which is really relevant to our province. And we're particularly affected by that here in New Brunswick with an aging population. So really highlighting our need for real-time data to better serve our patients. Whoops, hopefully I can't make the slide turn. I'll try to make that work. Whoops. There we go. So challenges to meet the demand are not new, but at least in the past year, it's been particularly difficult in my mind. We've had to deal with COVID, and that's affected all of you in so many ways. As a cardiac surgical service, all our patients need to go through an intensive care unit, every single one of them that we intervene upon. And our pressures in our intensive care unit, we cover also the COVID unit from our nursing care. That's affected us tremendously. So that's been a tremendous drain on our resources, and we've tried to navigate that throughout the year. Not only the fact that also our staff are getting sick, and the surgeons also, and at times not able to be present. Nursing shortage and staff shortage in general is a reality that we're living through. And the shortage is a combination of many things. Here just highlights, we are obviously having more elderly patients that require services. We have a retiring workforce. And then we have a limited entry at the entry level from a school point of view. So that's a sort of a double whammy or triple whammy that you might imagine, that we are at a point where it's quite critical. And the more difficult it becomes for staff or support staff and nurses, the more potentially some may leave the workforce because of that. So we can't underestimate the constant pressure on everyone and our staff, that it certainly cannot be underestimated. Anyways, I will leave it at that. This is a discussion in itself, and I'm not sure I can solve that problem at the present time. So I explained that there are things that did not change with the Heart Center. The Heart Center, when it was created in 1991, we had 2 operating theater for cardiac surgery, and it's essentially been the same since then, but the evolution has changed quite a bit. So the Heart Center is obviously here in the southern part of the province, and we serve the entire province. So a huge geography to cover, and obviously some challenges around that. We perform currently over 900 surgeries a year. That's the same 2 operating rooms from 1991 to 2021, with obviously more output from those rooms. So the capacity for an operating room for cardiac surgery in general is about 2 cases per day per room. So that would mean about 20 cases a week. And we currently perform 17.8 cases per week for 52 weeks of the year to achieve the 900. So our capacity is relatively, so we use quite a bit our resource in that manner. There are obviously weekend and night cases, emergency cases. Sometimes we need to do more. We use hybrid rooms once in a while. We obviously use a cath lab for TAVI. So there are ways that we manage to squeeze things out of, but that's just a perspective of trying to understand these numbers. So we are limited a little bit from that point of view. So the cardiac surgical volume has essentially been in that manner, has increased from the 300s in the year 1991 to, again, last year we went a little bit up from the year before, despite the challenges of the pandemic and losing 1 surgeon at 926 cases. And that's important. And so 926 patients at intervention, mortality rate overall 2.5%. That includes all comers, all the ECMO patients and the dissections and all that. So overall, we are doing well from that point of view. This is really important and highlights the hard work that people are putting in to what they're doing every day. Transcatheter valve are a big part of what we do also. Transcatheter valve are plateauing a little bit the last 2 years, 126 last year. And you can see this was a steady growth from the 2010 when it started with 9 cases. So it is a large proportion. And if I put that in perspective for our aortic valve practice, this is all surgical aortic valve replacement and TAVR together. We perform around, so that the maximal number for the province is around 260, 270 or so aortic valve interventions per year. And that's been relatively stable with a little bit of fluctuations here and there. Last year was 2021 was the highest year. You can see that transcatheter valves are taking a larger proportion. The surgical aortic valve here in black are going down. This is not a surprise. So are we targeting everyone potentially in the province? There's probably still an unmet need here. The estimate would be around 350 per million. It gives you an idea. We're 800,000 or so. So we're likely close to what you'd expect for aortic valve disease for the province. So this is the kind of dashboard that I use to sort of look at the data on a regular basis. We do have this that's updated on a regular basis. This is essentially a dashboard in live time looking at our utilization. I can put here a date selector, the date. So this is the year of 2021. During that period of time, you can see that these are the cases that were completed. There were inpatients, outpatients, and transcatheter valve. The OR utilization, I mentioned to you, 95% of the time utilization is very high. And focus on this. It's particularly important to focus on that because it highlights that most of the patients we do are actually inpatients. It used to be almost 2/3 in 2020 at the beginning of the pandemic. Now it's a little bit less. But essentially means that 59% of patients are performed while in hospital. That means that their median wait time for that group is actually around a week. So a large number of patients are done within that period of time, which highlights an acute coronary syndrome, sick patients, and the demands are quite high on those patients, and obviously means that the other 300 and so that wait on an outpatient wait list end up waiting longer than you'd expect. So this actually looks at inpatients. The patients are done, within the standard, and the standard is within 7 days, 70% of the time, while the outpatients are supposed to be within 42 days, only 19 or 20% of them are done within the predicted 42 wait day time. And then we favor generally aortic stenosis patients because we believe that the risk to them is the highest, unfortunately. So it shows you how triage is really important in what we do, and it is challenging. So we use this dashboard also to look at wait list and how it behaves over time. And if I were to look at, you saw the number of cases we did from 2018 to 2022, it was a steady rise in cases. And despite the steady rise in cases being done, there was a steady increase in the wait list of patients. So the demands kept increasing despite us trying to address 15% more capacity that we did during that period of time. The only time we've managed to impact the waitlist has been in the last few months. For some reason, we've been able to impact that a little more for a variety of reasons. The same way as a TAVR waitlist, you can see that it fluctuates over time. And then in the late part of 2021, it was reaching 51 or so patients waiting for transcatheter valve, which is unreal for us. We've managed to bring that down to more reasonable levels in the 20, and hopefully around 20 or so makes sense for us, because that means a wait time of around 6 weeks at most for those patients, trying to address that. So again, these dashboards are particularly helpful in trying to see trends and trying to impact how we deal with our patients. In the same manner, we look at the period of time, and you can tell that there is still a number of patients that wait exceedingly long, 90th percentile. There are some patients that wait, a year for surgery for a variety of reasons, including the fact that, for example, asymptomatic mitral valve would be the most common one that is hard to, while they have indication for surgery, those patients are relatively safe. Same for very stable coronary disease with non-left main. These patients tend to wait a long time, unfortunately. The median wait time is really what's more accurate. It should be around the 60 to 90 days, which we haven't had since the year 2019. It's been really hard to keep that number, and we're trending down at the moment as we're targeting. But as I said, the more inpatients you do, the more urgent cases you do, the more it displaces the outpatients to wait longer, and then triage becomes exceedingly important. We also tracked adverse events while waiting, which is really important. During that year, there were 38 patients that were readmitted while waiting. And those 38 patients are obviously, 3 of those were due to STEMI or non-STEMI. So surprisingly, despite 500 or 600 coronary disease patients being done that year, many of which waited at home, only 3 had an acute MI for their readmission. So relatively low rate, so we triaged reasonably well. There were 5 unfortunate patients that died while waiting. Normally, we would expect 1 or 2 per year dying on wait lists. And some of these patients, I believe one of them died while in hospital. And it was a complicated renal insufficiency and all of that. So, but it still fits as a patient that was accepted for surgery and unfortunately demised. So these are tremendously sad events and are unforgivable in many ways, but highlights the demands and the resource issues that we're dealing with all the time. Whoops. So it does highlight the ongoing need for all of us to be involved and help in the triage. And thank you for all of you who are on the call today or listening to this in terms of helping us manage that. It really highlights how it's important to address the most urgent as much as possible, but the caveat, as I said, is a more urgent patient that we do. And if our threshold decreases for that, then obviously it means that other patients are going to wait that maybe you don't want them to wait. They need to be monitored regularly, and we try our best to do that. But unfortunately, it is almost impossible to be perfect at that. Aortic stenosis tend to be favored on the wait list and always most worrisome for those patients in terms of sudden death risk. And it really highlights our ongoing resource constraint and environment in which trying to address these wait lists are not simple solutions. Increasing capacity with an increased operating room doesn't necessarily mean you're going to deal with the problem, because you may not have the staff to staff that room. So the shifting of the problem shifts all the time, and it is an ongoing issue that we're trying to address. So sometimes a picture is worth more than words, and this is what I mean by the constraint in terms of space and resources. Our ICU is a constant for us, and this is, the largest space in our corner of our ICU. This is actually 2-bed space. The corner bed is the largest one, which we use for ECMO, and it shows you in an ECMO patient the kind of resources you require for these patients, with perfusionists, surgeons, nurses at the bedside dealing with the machine and the balloon pump and all of the things that are required for that patient. So while we want to provide the best care possible for patients, these are highly resource intensive. And this is another space for another patient that's essentially in the same space. So it highlights how difficult the environment can be to work, and hopefully there'll be some solutions to that problem as we move forward. So the promising move forward, and this is a design plan. Geez, this is our current block of operating room. This is the exact space where the 2 cardiac surgical theaters are. There is a plan afoot to eventually renovate some of this space here, which is a current recovery room, to eventually be a hybrid room, which will be a 3rd operating theater that will be possible or feasible for cardiac surgery. So that will expand our capacity tremendously, as you might imagine. This part of the building doesn't exist yet. It's an expansion that's been promised here as long as I've been here, and probably for 10 or 15 years for the people that have been here, to change or renovate our ICU. Maybe it's moving forward. The money's been allocated, government has approved, but nothing's moved forward over the years that I've seen. I'm really hopeful that there'll be a move for that over the next little bit, because this will mean a big change for us in terms of capacity over time, and hopefully get us in the right direction from that point of view. So what about our surgeon resources? Our team this fall is going to be, sorry for the pasted in picture, we really need a proper team picture. So Chris here, who's in the middle, taking Rand's spot. And then we have Ivan that's coming in August of this year. Ivan is currently in Bristol in England and completing a fellowship in valve surgery, will be joining us. And we are also recruiting actively right now for another surgeon, as Dr. Brown is planning for his phase out over the next several years. So we're really trying to plan our future and to really make sure that we fill the gaps when needed. So with that, I have a few parting words. In summary, cardiac surgery at the New Heart Center is really striving to keep up with demand, which has been challenging. And I'm trying to be as transparent as I can to give you the data that I have and what I know. We're really trying to promote innovation. I really could have spent today telling you about minimally invasive ECMO cases, TEVAR, valve sparing intervention, chip intervention, MitraClip, TAVI procedures. All these things are ongoing at the Heart Center and really promoting. We have 2 MitraClips being done today. We have a lot of chip activity, which is really high risk percutaneous intervention with or without support, with mechanical support, with ECMO, for example, in patients that we believe are high risk and are better served by this type of therapy than a high risk surgical intervention, for example. So none of this would have been possible without all the staff involved in the Heart Center and making this possible, and all the hard work that they've done, and that tremendous effort. And sometimes we forget that. So with that, thank you to everybody. And whoops, if I can change to the next slide. So thank you for all your support. I will stop sharing and open this to questions. Whoop. All right, stop share. There we go. Let me see if I've got some questions here. Whoop,
Hi, it's Ron. Can I interject instead of typing?
Absolutely.
Excellent. Thanks for the great review. I was just wondering, I know it's a small number, were you able to tease out the patients that were that died on the wait list? Were they mostly aortic stenosis, or was it coronary disease?
Yeah, 3 of the 5 were aortic stenosis. So it highlights how aortic stenosis is. And the last time we reviewed, I think we reviewed a 5-year period, no, sorry, a 10-year period. We had 21 deaths the last time I looked at it when I'd come here. And it was the majority of the time always aortic stenosis. But it's a little more than that. It's often a mix of aortic stenosis with heart failure or aortic stenosis with coronary disease. But aortic stenosis is a common feature, no doubt.
So going forward, and this is just a segue, noting that you're limited and you're already using all the capacity that you have, how do we go forward and prevent these deaths for patients with aortic stenosis that's severe? We've got a few patients that decline their ejection fraction before they end up in hospital, and unfortunately their LV does not always recover. What are your thoughts on that?
Yeah, sadly, there's no great way to predict, meaning that it doesn't mean the ones who wait the longest. So for example, several of those deaths were within the 42-day wait time standard. So it shows you that waiting doesn't necessarily, if anything, the patients that are asymptomatic waiting actually predict themselves for being able to wait longer, which is very sad in a way of thinking. So I don't have a solution, Ron, to that, other than, when patients start complaining or you're worried about them, the solution in my mind is admit them to hospital, and then that pushes the trigger to be done sooner. It is only tool that we have, unfortunately. And I know I speak to you sometimes when you're worried about a patient, we try to get them done the week after, that kind of stuff. But if you're really worried, admission and really upgrading them is the only way to really force the agenda. I don't have a solution or a good way to tell you, oh, let's do a stress test. Can we predict? Can we not? It's not very clear to me.
One other quick comment, if we need to admit them to get them down there, our
Yep.
hospital's a COVID cesspool, so I'll just leave that there.
Yes.
Leave room for
Yeah.
other comments.
So I didn't approach the COVID story, but the COVID story is one that's evolving, as you know, and it will affect outcomes overall. The outcomes post-cardiac surgery in COVID positive patients, recently COVID positive, even asymptomatic, is worse. There's no doubt that these patients are affected in multiple ways. And it is the same thing, talking to my interventional colleagues this morning, that there is a lot of concern for percutaneous interventions in those patients also because of microthrombotic issues going on bypass with inflammation, systemic inflammation, staying on oxygen dependent for weeks after surgery. Those are all concerns that we have. And now, we have 5, I think, in our current CCU that are positive, that are waiting some intervention. Like, we don't know how to best stratify these patients. The current recommendation are wait as long as you can, but those are broad recommendations that sometimes you're forced to intervene when you, so it's really becoming more challenging, no doubt.
And I said I'd leave room for comments for others, but I do want to say thanks for all the great work you're doing, and thanks for that great update.
Thank you very much, Ron. Oh, I'm sorry, guys. You saw my presenter view the whole time. I'm sorry, Ron. Somebody should have said something before. Oh, well, hopefully you saw the slide. With that, I'm going to close for today then. Thank you very much. Have a good day.